Hi, so I'm here with Adam Lowe, who was on the NICE Guidelines Committee that issued its final guidelines in October of 2021, more than a year ago. We've had enormous pushback, or there's been enormous pushback from people that one would expect there to be pushback from. And so we've learned that there's an editorial or an opinion piece or whatever going to be published, signed by dozens, it seems, of PACE authors and their supporters and other people that we know of who are publishing this critique in a major neurology journal about the NICE guidelines and the 8 supposed mistakes that members of the committee made in coming to their determination. So we haven't seen the full paper yet. They've made some of these allegations before, or these criticisms, but I did want to talk to Adam and have you here just to go over these 8 points quickly and kind of rebut them. I will alert people that my video has been malfunctioning, and so I may start doing, my camera may start doing psychedelic impressions during this, in which if that happens, I will turn off my video and we will just be able to see Adam in all his glory telling us about the situation, and I will just be an audio voice. So Adam, thanks for being here.
Thank you, David. Thanks for having me.
I'm sure you've seen these objections before, but let's go through them kind of one by one. And so the first is that the group created a new definition of CFSME, which automatically downgraded the certainty of trial evidence. So what's your response?
Yeah, so this was something that they claimed during the stakeholder comments as well. And obviously it didn't have any traction with NICE because we haven't invented a new diagnosis, a new, illness or anything like that. It's basically the IOM criteria, the Institute of Medicine criteria, that have just been operationalized for use on the NHS. If anything, the 2007 guideline, which some of the authors of have now contributed to this this letter claiming that there are the 8 errors, that was potentially more fictitious in that they just basically took bits and bobs from whichever criteria they liked and made up their own criteria based on that. So I mean, really it's a hypocritical comment, but it's also just factually incorrect.
What is the basis of it? What is it that they're pointing to try to make that point?
I think for them, they want to undermine anything that that calls into question their evidence, the evidence that they have authored or that their colleagues have authored or that they've made money from or reputation from. And so in that respect, they've looked at what's happened in the guideline and the evidence review. And they've looked at how the evidence was downgraded for indirectness. And so they're specifically trying to target that complaint. I guess their hope is that NICE would look at this and be like, oh no, we've got it wrong somehow, let's go back and change it, and that maybe that would then re-upgrade the evidence, which, well, that won't happen anyway. But even without that, the evidence was still uniformly low, and a lot of it was still very low. So I don't think it would make any difference. But I think this is part of the attack, the line of attack that we're going to see and that we'll continue to see, which is just to basically criticise every decision that the committee made and that NICE made in order to throw doubt onto the guideline itself. And I don't necessarily think it's about winning an argument, because they never honestly respond to anybody who responds to their work. If you point out the flaws in their arguments, they don't respond to that in good faith. They just continue to say the same thing over and over again.
It's very,
yeah, exactly.
It's very Trumpian. I've always found it to be very Trumpian. They repeat the same things that have already been rebutted. Okay, so let's go on to number 2. Omitted data from standard trial endpoints used to assess efficacy. What are they talking about?
So they're talking about the endpoints, aren't they? So when the trials say that they're done, when the evidence shows that, you know, in their eyes, that the trial is over and whether there's a benefit at that point or not. I mean, one of the important things to note was that this varied massively across all the different trials. Some of the trials were really, really short. Some of them were a lot longer. You know, you can't just say, oh, well, we need to check everything at certain lengths of time. So NICE had suggested, because this is what they often did, that we look at the, you know, the latest endpoint for all the data that we've got. So
You
that
mean
we
the most furthest out, you mean the latest?
Exactly, exactly. So if they've looked at things at 6 weeks, 12 weeks, a year and 2 years, then we look at the 2 years data, because that is the closest reflection to how this will impact people in the medium to long term, especially when you've got a long-term condition. That's what's important. Crucially, what I find really interesting is that some of the signatories to this latest paper who criticise us for using the latest endpoint actually criticised NICE for the exact opposite when it came to the depression guideline. So they actually pointed out, said, oh, why have you not gone for the last endpoint on all of these trials on depression? You've not done that. You've only gone for, you know, the endpoints that were published in the trials, or, you know, whatever the case was. So they've actually complained to NICE about the exact opposite problem when it suited them, when it was about depression. And there's many of the same signatories on that letter complaining to NICE about depression, as on this paper that complains about the new NICE guideline for ME.
So just to clarify, the fact is that the different papers all have different endpoints as their primary outcome, and so or often have different endpoints right after the intervention or a certain period of time after. And so you're trying to standardize at what point you were looking at the results.
Yes, so it was partly about standardization. It was also partly just to be pragmatic, that we need to understand what the effect of these treatments is in the medium to long term, especially when they're being delivered in clinics. And there's a huge absence of clinical data, you know, so it is helpful to know whether these treatments actually have an effect at long-term follow-up. If people are doing a 12-week course and they report that they're slightly better during the course of the treatment, but then that drops away at week 13, then that's useless, you know, because that might be a very expensive treatment that actually is only useful while people are doing it. And then you have to ask, well, how useful is that? So we were looking at the latest endpoint so that we could extrapolate from that how useful these effects were and how enduring they were. And that's really, really important, because if you're going to see a placebo effect, or if you're going to see any kind of response bias, or, you know, role play between the patient and the researcher, all of those things you would expect to show an improvement in the early days, in the you know, short term. But then when you get to a year or 2 years out, then you would expect those things to disappear. So it is important that we look at that latest furthest endpoint. And it wasn't just something that we did for the NICE guideline for ME. You know, this was something that NICE do quite regularly, and that they saw a standard. So this was the thing that they recommended that we do, because all the trials had so many different endpoints, you know, and we wanted to be sure that the evidence that we had was applicable to patients with a long-term condition, and that it wasn't just going to be a drop in the ocean.
Right. Okay. So that's number 2. So number 3 is discounted trial data when assessing treatment harm in favor of lower quality surveys and selective comments from qualitative sources. Okay, so this is basically the argument that their own studies and their own inadequate studies did not show apparent harm, but the reports of harm generally come from the surveys of patients who've done these treatments. So they're saying, I guess they've proved that there is no harm from their studies. And we know the level of evidence that they have in their studies. But anyway, I think that's the argument. So what's your response?
Yeah, I mean, it's an interesting, you know, it's an interesting area to talk about harms, because of course, there isn't much about harms in any of the trials. The nice technical team, who were not part of the committee, I might add, who didn't know anything about ME, most of them, they just spend all the time crunching the numbers. You know, they were the ones who came back to us and said, there doesn't appear to be very good reporting of harms in any of these trials. We can't see what they mean by X, you know, when they say, oh, there've been some adverse events. The information that was given was quite sparse, it was quite limited. They were unable to determine whether there was adequate reporting of harm within the trials. Now, this is something that patients have been saying for a long time, that there isn't adequate reporting of harms. Even when you read the protocols for the treatments, such as graded exercise therapy, such as the NICE manuals that were used by therapists, they say that worsening is not harm. If you worsen while you're doing activity, that is to be expected, and therefore is not logged as harm. So even within their own protocol, they're admitting that actually there is a bias against reporting of harms within the actual structure of the treatment modalities.
Because it's constructed, because it's framed, any symptoms are framed as non-harmful.
Exactly. So the way that they would argue is, oh, well, it's a fluctuating condition, you know, people are better, sometimes people are worse. So if people get a bit worse or a bit better, then we can't include that. But you know, they don't explain what is considered to be a normal increase in symptoms. The protocols basically are just quite blasé about the whole thing, that we should expect some worsening and that actually is not harm, which then biases people against recording adverse events as harm, because they will just think, oh, this is you know, to be expected, this is normal. And where they don't see it as being normal because the person is increasing their activity, then it gets blamed on, well, you've got an illness that fluctuates anyway, so that's what we're going to say it is. Now, the second point.
The argument against the surveys, of course, is that they're, you know, non-representative, that we don't know who they are, the people responding, that we can't rely on them as valid evidence, and so on and so forth.
Exactly, but actually that's false, because in a lot of instances, in a lot of other conditions, it usually is things like survey data that shows harm for things. There aren't ideal ways to record harm, especially when it comes to therapies. You know, there is the yellow card system for drugs and appliances, but that doesn't apply to therapies. So there's a different standard in terms of how people are able to report things, which means it's much harder. So when you look across loads of illnesses, actually, there's loads of anecdotal evidence and there's loads of survey data, which tends to then be taken seriously. But I would also add that there's 20 years worth of patients reporting harm for graded exercise therapy. It's not just a recent thing. It's been going on for over 20 years. There are over 15,000 respondents in the pooled data that Keith Geraghty and his team put together. So that says to me that that's a very large amount of people. It's more people than were in any of their trials, for example.
So your point is basically that it's not one survey. This is a consistent finding over many years and many surveys. And so it's harder to believe that it's just kind of, you know, it's not just a random bad survey.
And even if we say that it's only the people that have negative responses who are filling this in, or, you know, it's the majority of those people who are filling it in, that still accounts for a substantial number of people that have been harmed in any country. So, you know, if there's 2,000 people in the UK that are responding to a survey and 80% of them are saying that they've been harmed, that's still 1,600 people in the UK that have been harmed by graded exercise therapy. How many people are being seen in clinics each year? Do you know what I mean? It's not a huge number of people in the first place. So for 1,600 to be harmed, that's significant. Those are significant numbers. And the other thing is that there were clinicians in the room, there were researchers in the room, there were patients in the room. We all agreed that this had happened, that we had known people that had had these experiences, that actually it happened, you know, fairly regularly. So there was extra added knowledge in the room where people were saying, actually, yeah, we know this happens. We're not going to deny it. We're not going to gaslight patients, you know, which is really, really offensive, and say that it doesn't happen, because they said, actually, yeah, we know that it does happen. And, you know, sometimes the reasons that it happens are not predictable. Like, we can't say person X always causes harm because they deliver it wrong. Person Y always causes improvement because they do it right. Actually, the people who are doing it right, or right in inverted commas, according to the protocol, are the same people that are often harming people. So there's no way for us to be able to measure either, you know, which version, which get is going to harm which people. All of it is potentially at risk. And they did complain about the subjective element of that, you know. But one of their arguments that they keep going back to is that ME is subjective and all the symptoms are subjective, and we need to listen to patients, you know, but except when the argument doesn't really work in their favor, then they don't want to.
I see. The argument is it's all subjective, but that's what their whole trials are based on, subjectivity to begin with. So it's not really fair to say, oh, that's just the patients being subjective, complaining about their pains.
Exactly. And the other thing that is worth bearing in mind is that actually the threshold for harms, the threshold for evidence of harms, is necessarily lower than the threshold of reporting benefits, especially because benefits can be recorded because of placebo. You know, that's why thresholds are so high, to avoid various forms of bias, to avoid various forms of placebo from people wanting to report a positive effect so that they can get more research, so they can get more funding. You know, there's lots of reasons why the evidence is set quite high, but when it comes to harms never receive the same level of research. They never receive the same level of care or rigor in the recording. And you always have to set the threshold much lower, because the first principle of being a doctor is first do no harm.
Okay, let's move on to the next one. I think we've covered harms. So 4, downplayed the importance of fatigue as an outcome, even though it is the primary symptom of CFS ME.
I know, it's like we've gone back 30 years in many ways, isn't it? I mean, most people who talk about ME don't talk primarily about the fatigue as their major symptom. And when they do, it tends to be very early on. But when you look at other conditions, for example, fatigue is one of the most complained about symptoms across the board. But what tends to happen is, when you look at the evidence, after a certain point, people stop complaining about the fatigue. And one argument is that maybe the fatigue is self-resolving, but I don't necessarily agree with that. I think what actually happens is that people then find more specific things to then talk about, because actually, when an illness is vaguer, you don't know what's going wrong, you don't know what something feels like, you might say, oh, I feel tired, or I feel fatigued, or I've got no energy, because that is the first thing that you notice. But actually, as you learn more about your illness and you learn about its triggers, you would actually start to describe that in more specific ways. So a person who has MS might initially complain of fatigue, but as they learn more about their illness, they might then describe a more complicated pattern of symptoms, because they've got better language to describe what's going on with their experiences.
So what is it that they mean when they say that you've downplayed the importance of fatigue in the guidance?
I think for them, they mean that because we had a particular focus on post-exertional malaise, that somehow that meant that we said fatigue wasn't important. But that's not actually true, because when you look at the criteria, fatigue is the first thing that comes up. Post-exertional malaise is second. And the reason for that is because we did and ah, and we talked about it a lot. And actually, we are aware that fatigue will be the thing that people will present with first, because they may not know what post-exertional malaise is. And it may not be until later on that they have the language and they have you know, the understanding of their own illness, that they can then talk about things like post-exertional malaise. But also, every single set of criteria included as the default fatigue. So it wasn't necessary to then substratify the criteria on whether they included fatigue, because that was taken as read in every single set of criteria that we did, and was a baseline for every single piece of research that we looked at. So you don't need to stratify evidence on something that is present in 100% of the evidence. It doesn't make sense. You'd stratify the things that are not included within their definitions of the illness to see then if you're still talking about the same illness. And fatigue was really, really common in all of them. Obviously all of them mentioned it as a major symptom. But also unrefreshing sleep was another one that was really common, and cognitive symptoms was usually pretty common. So the one that wasn't, the one that was a bit more patchy, was post-exertional malaise. And even when they did talk about post-exertional malaise, they didn't always describe it in a way that was convincing that they were talking about the same thing. And that's why we took a closer look at that particular symptom.
So in there, they're talking about really downgrading the ratings for indirectness. I think probably because you were not you were taking anything that didn't have a very high threshold of people with identified PEM and marking it down a grade for vagueness, I guess it was.
Yeah, because essentially you don't know whether you are looking at the same cohort of patients as the patients who are typically ill now and who are represented by the evidence base. And that's part of the difficulty that we ran into. When we compared the different criteria, there was a lot of overlap, but there were also different focuses in some criteria than in others. And just because Dr. So-and-so believes that ME is one thing, it doesn't necessarily mean that he's right. What we have to look at is what all of them are saying, and if there's a pattern, if there is a trend, and we have to try to get get to the heart of that patient group, who is represented, who is included within that, and how relevant and modern those definitions are, because our understanding necessarily changes as time goes on.
Right. Okay. So number 5 is failed to synthesize and grade trial evidence adequately. They're basically saying you didn't use the grade system correctly, I think.
Yeah, and it's just ludicrous, isn't it? We looked at, I think there was 300 pages for pharmacological evidence, 600 pages for non-pharmacological evidence. I think that was condensed for the website for what you can actually access, but there's still hundreds of pages on there of grading that's gone on. And it wasn't us that did the grading, it was the independent technical team who grade all the nice stuff. So it wasn't just that they decided to do it differently for us, because that's not how it works. They use the same process that they use for everything else to arrive at those gradings. And the interesting thing was that, yes, some stuff got downgraded for indirectness because the criteria were outdated and it didn't seem like they had properly accounted for post-exertional malaise, but a lot of the trial was very low quality evidence or low quality evidence even before that, and there were still problems with the data that we looked at. So it wasn't as if there was just one area where everything was suddenly marked down, because that's how we wanted it to be.
And grade presumably allows for some discretion. I mean, it's not a science exactly. It allows for some judgment and discretion.
Oh, absolutely. And that's why with the Cochrane review, when the editor asked them to have a look at it again and see whether they should change some of the recommendations or change the strength of language, you can see in all of the responses that have come out via Freedom of Information, they've said, well, yes, you could do that, but in our opinion, we want to keep it this way, or we would rather keep it this way. So, they have these same people that are complaining, some of them have also used their discretion, for example, during the NICE 2007 guidelines, to use their own interpretation in the way evidence is rated. And grade wasn't used in the original NICE guideline, but a similar, an alternative process was. And most of their argument still boils down to, in our opinion, we don't think you did it right because of X, but it's all in their opinion, essentially.
Okay. So number 6 is misrepresented graded exercise therapy as mandating fixed increments of change when the major trials defined it as collaborative, negotiated, and symptom dependent. Well,
yeah.
What do we say?
Negotiated, perhaps. Collaborative, they do call it collaborative in a lot of the material. Symptom contingent they don't use. That is a term that they associate with pacing. So I think that one's an outright lie.
Wait, that was a term that they say it again?
symptom contingent, because symptom contingent
they did not. That's not
pacing is pacing basically. Yeah.
Right. I mean, I wouldn't say that the descriptions in PACE is symptom dependent. It seems to me that it's the presumption is that there's nothing wrong and you just keep going forward.
Yeah, exactly. And, you know, it talks about how you should increase by 10 to 20% every week or every 2 weeks. And then this must be maintained for a week before changing anything. So the implication is that if you get worse, you have to continue trying it for a week before you're then allowed to go to your therapist and say, please, sir, can I do some less? You know, that's not collaborative at all. And the negotiation, like, why should I have to negotiate to do less of something that's harming me? If it's harming me and it's truly symptom contingent, then surely I can do less straight away without asking for permission from, you know, one of these professors or researchers, you know, that is in control of the trial. So it's simply not true. And when you read the actual protocol manuals for the therapists, they're very clear on what it is. They're very clear that an increase in symptoms is not a reason to stop the treatment. They're very clear that some increase in symptoms is to be expected. They are very clear, even in a lot of the trials, that there is no underlying harm being caused by graded exercise therapy because there is no underlying illness in essence. You know, we just need to disabuse patients of the notion that they think that they're ill and help them recondition in a way that is not scary to them, so that they eventually stop associating activity with symptoms and get out of that vicious cycle of, you know, feeling ill every time they do it.
Yeah, the vicious cycle. The vicious downward cycle, or downward spiral. Okay, we've heard that a lot. Okay, so let's move on. We've got 2 more to go. We're doing well here. So number 7, deviated from NICE recommendations of rehabilitation for related conditions such as chronic primary pain. What are they talking about?
I mean, that's just daft. It's like saying, oh, you're treating an apple different to an orange. And it's like, well, yeah, because an apple is not an orange. So I think in their point of view, they're arguing that the guidelines should be more like the chronic pain guidelines. But what's important to note is that loads of clinicians actually also responded against the chronic pain guideline, saying that they disagreed with it vehemently because of the way that it downplayed medication, and in some cases recommended not to use medication and put more of an emphasis on things like CBT and acceptance and commitments therapy. So essentially, you know, they're saying, why have you not made it like another guideline that was also controversial? Because that's what we prefer. That's essentially what it boils down to. We prefer this guideline, even though it was controversial. Why didn't you not do it that same way? But ultimately, chronic pain is not the same as ME. ME is a specific illness. Chronic pain refers to a variety of conditions, some of which will be, you know, more or less the same, some of which won't be. And it's not appropriate to necessarily say that you should treat them identically, you know.
Like even if chronic fatigue also, I mean, chronic fatigue is not chronic fatigue syndrome.
Exactly, you know. So I understand that for some people they prefer to lump and keep everything together, but actually that can be harmful. If everybody who, you know, had diabetes was all treated the same, despite having type 1 or type 2, then obviously that's going to cause real problems because type 1 and type 2 are not the same.
Right. Okay. And now we have one more. Recommended an energy management approach in the absence of supportive research evidence.
So, I mean, it's ironic really, because in CG 53, which was the 2007 NICE guideline, and I know I keep saying it's ironic, but there was so much glaring irony that you have to assume that either they're being disingenuous or, you know, they're just not that smart. I mean, I'm guessing it's the former. But they introduced activity management in CG 53. So some of the same authors of this paper,
which they just made, I mean, they didn't have they study it, they just put it in there, right? They didn't have,
yeah. exactly. So activity management was put in without any evidence base in CG53. Energy management is basically just a bit of an evolution of that, really. And you know, they might say, well, it's not evidence-based, but they were perfectly happy to have something else that was not evidence-based in the first guideline. And their argument would have been, well, that's because clinicians thought it was useful. And that's exactly what happened this time. The reason why there's energy management in there is that the clinicians in the room thought it was useful, the researchers in the room thought it was useful, the patients did. There was already activity management, which had a slightly different emphasis, but was overall very similar. And when we looked at all the evidence, it was really interesting to look at the things that patients continually reported as being helpful in the trials, because we didn't just look at the numbers. We didn't just say, this worked, this didn't, you know, which is what IQWiG have done, for example, in the Netherlands, or what Cochrane have done. We actually looked at every single protocol, all the data that came out of that, all of the patient responses, and there were loads of themes that were moving through things. So when people were allowed to dial things back, that was really, really important to people. When there was recognition of things like relapses and worsening of symptoms, that was often really, really important to people. Also having that positive relationship with the clinician was also really, really important. So we were able to see from these themes that there was stuff that it seemed like it might work. And so we had to talk about whether, is there going to be any risk of harm from these things? Because obviously you can't just recommend things that are going to cause harm. But if they're essentially free because nobody has to pay for an expensive therapist to deliver these, to deliver energy management, you know, it's just something that patients can be educated on with leaflets or, you know, a talk with their GP or a specialist or whatever. There's no cost, there's likely to be no risk of harm, you know, and it was a theme that was continued throughout all of the evidence that we looked at. Then we were like, actually, what's the risk in suggesting this? Because a lot of clinicians will want something that they can offer their patients. They will want to give some advice to their patients. There is the argument that you don't want to give them nothing and say, oh, there's nothing we can do for you at all. And from a harm reduction point of view, actually, it makes loads and loads of sense to tell people to avoid the stuff that could potentially cause them harm. Because another theme that emerged throughout everything was that, especially early on in the illness, when people pushed through, that's what made their illness worse. And for many people, they suspected that may have been what caused their illness to become chronic. So it costs us nothing. There's no risk to just say to patients, if you're getting a bit, you know, if you're still a bit ill after having a virus and it's been a while and you don't feel like you're getting better, maybe don't push through, because that might make you a lot worse, and then that's going to cost the NHS even more money. So it was just a pragmatic, sensible thing to do, and in many respects, it's been better embraced by the patient population and most clinicians than activity management was anyway.
Okay, Adam, thank you. That was a very brisk overview of these 8 points, and I will, I think, try to post this later today as a preemptive message for
as
those.
A pre-buttal. As a pre-buttal.
A pre-buttal, yes, as a pre-buttal. I had thought one time I made up that word, but then I found out that other people had used it before me when I looked it up. Anyway, thanks, Adam, and Happy New Year and all that stuff, and hope you're having a good holiday week, and I will talk to you soon. Thank you for spending time. Okay,
Thank
bye.
you. Have a wonderful time, yeah.
Okay, bye.